Sorry for the delay. We were having some challenges with technology this morning. We will give our speaker a couple minutes to get herself set up and get her presentation going. But before we get to that, I'll just make some announcements. Thank you very much again to all of you for your participation and for being here. Remember, our schedule is fixed. It's the second Wednesday and the last Friday of every month. We plan to try and have presentations up until the end of November. If there are additional presentations, we will let you know. And today we would have all been meeting face to face at Research Day. Research Day has unfortunately been postponed this year because the presenters were not able to finish their research projects as a result of the COVID situation. So Dr. Halliday will get back to us on Research Day and what the process might be for Research Day moving forward. And so today we have Dr. Dominic Turnquest, who's going to present to us. And she's no stranger to most of you. Most of you will know her as a consultant in the Department of Anesthesia. She's also actively involved in management of COVID patients at this time at the Princess Margaret Hospital and the outside facilities. Dominic Turnquest has been practicing medicine since 2010, having been enticed by medical research at the Tropical Medicine Research Unit. Her medical degree was obtained from the University of the West Indies in Mona. During this time, she discovered her love and passion for anesthesia and vigorously pursued it as her specialty. Her professional interests include cardiothoracic anesthesia, regional anesthesia, and intensive care. Her personal interests include learning all things new, instruments and languages, and include pursuing her Christian faith. So let's welcome Dr. Dominic Turnquest, and thank you for presenting to us today, Dr. Turnquest.
Thank you very much for that introduction, Dr. Black. I am going to start my screen share now. Okay, can everyone see my presentation?
Yes, we can.
Okay, perfect. Okay, welcome to my presentation on critical care outreach in the age of COVID-19. The topic that I'm going to really cover is the management of hypoxia and just some of the practical aspects of that. I have no disclosures, no conflicts of interest to declare. All right, so when we talk about critical care outreach, that could be a lecture in and of itself. And the truth is that I have actually presented something on that before, about 2 or so years ago. And the term outreach is used to describe the delivery of critical care services outside of the intensive care unit. It is described as critical care without walls. And essentially, it's going to be where teams with an intensivist, sometimes a respiratory therapist or a nurse, with critical care training are dispatched to areas where patients may be deteriorating. And these areas could be wards, they could be satellite clinics. But the goal of the team is to early recognize critically ill patients and to provide interventions so that major adverse events such as heart attack, stroke, respiratory arrest, cardiac arrest, or death are prevented. And so throughout the presentation, I'll be sort of extricating myself from the ICU and giving sort of relevant practical advice that you can implement in your setting. All right, so why in the COVID era? Well, of course, we're in a pandemic, but we have a lot more satellite sites. And one of the goals of the critical care team is to provide critical care expertise and experience in a manner that empowers healthcare providers. The truth is that the critical care outreach team works best when the staff in these areas are provided with the knowledge and just the experience of interventions that allow patients to have their deterioration recognized early and to have interventions performed early. So I am keeping in mind that this lecture is being made mostly to SHOs who are located in these areas. And so I'm not going to be covering intubation because that's going to be mostly for specially skilled individuals to perform. But then I'll be covering most of the practical aspects. And so this is the case description. It's not of a patient, but of staff. It's staff-centered as a result. So the case is of a 28-year-old senior house officer who is in the first year of their specialty, the specialty of their choice. And unfortunately, due to the crisis of pandemic proportions, they've been placed in a satellite clinic. During one of their ward rounds, it was discovered that a nurse felt so one of their patients didn't look good. And so the good senior house officer went to attend nurse's concern and found that the patient who had been on minimal oxygen now has worsening tachypnea and is asking for the doctor to help them. They're not feeling good and they're pulling off their mask. And starting with airway breathing circulation, the senior house officer discovers that the saturation is 40%. Fortunately for them, however, an anesthetic consultant was already on the compound reviewing someone, and they asked the nurse to quickly get the person. When the consultant arrives, the patient says, "Doc, I don't feel any air blowing." And when the oxygen tank is assessed, it's on empty. It's quickly replaced, and after 15 minutes, the oxygen saturation comes up to 96% on 15 liters via face mask. So oftentimes when ICU is called to help with a deteriorating patient, we arrive to find that the concerned healthcare provider is anxious, tense, they're uncertain of what to do, and they are fearing the worst for their patient. For such individuals, I actually applaud your compassion, but I'm hoping that with the lecture that some of the fears will be allayed and that you'll be armed with the practical tools for management of such situations. All right, so the first thing we're going to talk about is monitoring oxygen tank levels. Okay, so oxygen is actually supplied to healthcare facilities in two main ways, primarily as piped oxygen. And as we see here, these liquid tanks are one method. They're huge J manifolds. They're actually in the Princess Margaret Hospital located just outside maintenance over by the parking lot, the staff parking lot. There are three of them there. And they actually vaporize the oxygen for delivery to the patient. When the piped oxygen is not available or you need an additional source, oxygen can be supplied in cylinders, and those are available in various sizes, lettered A through M. The most common cylinders that we'll see are the E cylinders as well as the H cylinders. The E cylinders are the 2-foot high ones that we sometimes use for transport. And the H cylinders are the 4-foot high cylinders that we will see sometimes on the ward for patients who are receiving oxygen on the long term, or we may see it attached to the ventilator. So the piped oxygen supplies, monitoring that falls mainly under the purview of biomedical, the maintenance team. And there are built-in alarm systems that let everyone know when the oxygen level is going low. But whether or not you're monitoring piped oxygen or the cylinders, the pressure gauge is the way to tell whether or not it's adequate. Okay, so oxygen exists as a gas at room temperature. It also exists as a gas within the cylinders. When gases are kept in a fixed container, they exert a pressure against the walls, all right? And that gives us the pressure reading on the regulator gauge. As the volume of oxygen falls, so does the pressure within the container. So we can conclude that the pressure and volume are proportional, which is a nod to Boyle's law, P1V1 equals P2V2. Therefore, if I know the pressure on the regulator, I can determine the volume and what is left within the cylinder. All right, so we often see the gauge looking like this. And in red, we have pressure within the units of pounds per square inch gauge. There are other units as well, kilopascals bar. But the important thing to know is that full E cylinders are filled to a pressure of 2200 PSI and contain 660 liters of oxygen. There are some sources that will say that E cylinders are filled to anywhere between 1900 and 2200 PSI, but by far and large, 2200 is the common figure. And here's a little quick cheat equation. The time remaining in hours is equal to the pressure in pounds per square inch over 200 times the flow rate in liters per minute. So for example, if I get a full E cylinder and I set the patient's oxygen flow rate to 1 liter per minute, how long do I have before it goes out? And that's simply the 2200 PSI that we see on the gauge over 200 times the flow rate, which is 11 hours. So I have 11 hours before this oxygen empties at the current setting of 1 liter per minute. Here is another example. I'm reviewing a patient and the regulator that I'm looking at has 1100 PSI on it. That's roughly half of the 2200. So I can conclude that the patient has approximately 330 liters of oxygen in the cylinder. If the patient is receiving 5 liters per minute oxygen, then how long is this oxygen cylinder going to last? And that's simply 330/5. That gives me 66 minutes. I have about an hour left, an hour's worth of oxygen left. So you wouldn't wait until the hour has passed, to get the extra cylinder. We'd get it at around 45 minutes before that. But more importantly, say you have to transport the patient somewhere and the ambulance ride is 30 minutes. Then you can transport the patient with a half tank of e-cylinder with some more confidence that you're not going to run out, because at the current setting, it would last an hour. So the H cylinders are also filled to 2200 psi. Remember, those are the ones that are about 4 feet high and most times attached to our ventilators. But because they are larger, they contain 6,900 liters of oxygen. And just for completion, if you do have to check on your pipeline oxygen, it should read about 4 bars, which is about 400 kilopascals. They're easily converted between pounds per square inch, bars, millimeters of mercury, and kilopascals. All right, so we're going to talk a bit more about oxygen therapy. And this is one of my pet peeves. We have to ensure that oxygen therapy is humidified. It should be kept moist and warm. Once a patient is receiving more than 3 liters per minute, then we'll start to see some of the ill effects of giving dry oxygen. All right, so we want to keep in mind that these are distressed patients. So they're going to have high respiratory rates. They're going to have high inspiratory flow rates, sometimes as high as 120 liters per minute. When they're pulling in all of that volume and at such high rates, the minute volumes are high, the work that the nose has to do to warm, filter, and humidify that respired gas is overwhelmed. All right, so they're gonna be increased insensible losses and increased energy expenditure. Without humidification, this dry, bone dry oxygen from the cylinder or the pipeline is gonna dry the mucosa. And that leads to breakage, to nose bleeding, which we have seen. And not only does it cause nose bleeding, but more in the distal airways, it can stop the mucociliary action, can become impaired. So as you can imagine, then it becomes difficult to expectorate, to bring up the secretions. And not only does the mucosa dry out, but the secretions themselves dry. And when they dry, they become thick and they can so inspissate within the airway that we effectively have a patient with airway obstruction. And not only does it cause these horrible cascade of events, but it also drying out of the airway also exacerbates bronchoconstriction. So I highly recommend using oxygen therapy, using humidifiers routinely on your patients. It's as simple as filling the humidifier about halfway with sterile water. Sometimes there is a mark on the humidifier. And as an aside, if the humidifier isn't bubbling, then it likely has a leak and needs to be tightened or properly screwed on. So even though oxygen has, of course, life-saving benefits, there are, in addition, risks. And one of the first risks that I want to point out or highlight is that of fire. Yes, oxygen is non-flammable, but it is an oxidizer, and that forms one of the triad that's required for fires to start. We need ignition sources as well as fuels, which could very well be the patient. But ignition sources can be a lot of innocuous things, like even fabrics that generate static electricity, such as wool, nylon, or even the use of electronics. How many of us, when we are plugging in chargers, notice a little spark, or maybe the charger isn't properly grounded? I just want us to be aware of that and to always know where our fire extinguisher is. So when it is that we are giving oxygen, of course it is a drug, and there are risks with it being overdosed, known as hyperoxia. And that is largely as a result of the generation of reactive oxygen species. Usually the glutathione system is our main antioxidant system, but it can become overwhelmed. And with the production of hydrogen peroxide or hydroxyl ions, we can start to see some of the CNS effects, widespread cardiovascular effects, respiratory effects. This is usually seen when our FiO2s are high, higher than 60 within 1.5 days. Or if our FiO2 is over 80, it can start to manifest within 24 hours. If we keep a patient on an FiO2 of 100, then we start to see some of these deleterious effects within 12 hours of onset. And some of these effects are permanent. So we know in premature infants, we can have proliferative retinopathy and bronchopulmonary dysplasia. With regards to the CNS, sometimes these patients get seizures, ocular manifestations, ringing in the ears. With respect to the lungs, sometimes we can see pulmonary fibrosis, and that's not reversible, and that starts within 12 hours of being on 100% FI. But these patients are also at risk of absorption atelectasis as well, widespread arterial vasoconstriction, and of course, in patients who have COPD or OSA, they can have hypercapnia, hypercarbia as a result. And that's why these patients need to have their oxygen levels monitored. And the target, especially in severe ARDS cases, should not be to get saturations over 95. Sometimes we have to accept getting sats over 88 in some of those cases, or 92 in moderate cases. It varies based on the clinical scenario and the severity of their COVID infection. But as well, if we have ABGs, we should be doing it if we have it available, so that we can monitor our patients. They should not be given more oxygen than absolutely minimally needed to achieve our target saturations. Okay, so one additional point is, do not take the patient off oxygen to measure saturations on room air. That is something that is an academic pursuit, really, because it is of no benefit to the patient. It takes a little while or a long while for patients to re-equilibrate to receiving oxygen via face mask and for their saturations to come up. There really is no benefit in taking the patient off the oxygen support that they are receiving that we know they need, just to see how low they can go on room air. And the patient's body undergoes changes during that time. It triggers hypoxic pulmonary vasoconstriction, for example, and that can have that can affect the pulmonary pressures, which can affect the cardiac output. It really is not of any benefit to the patient. In caring for these patients, we also try not to, along the same vein, not to break the circuit at all. If we can lengthen it, then the patients can go to the bathroom while receiving their oxygen. And that's simply by connecting our oxygen tubing end on, more than one end on, or we can just keep a spare e-cylinder with face mask for use in the bathroom. Okay, so how will you know to call the critical care outreach team? Well, by the time you would have called us, these are patients who probably were on 15 liters via face mask and still not doing well, not getting their sats into the target range. But we prefer early consults because that does buy the patient some additional time. And so if you find that the oxygen requirements are increasing once they exceed 10 liters per minute, the team should be called. Or if you have patients whose saturations are, have fallen to less than 92 suddenly, or have a respiratory rate over 32, these are good ballpark indications for calling the team. And then of course, there is the I just don't like how they look referral, which is okay, as long as you're able to give the objective data so that we can sift through to decide whether or not the patient is a valid referral. Okay, so I will be talking about the oxygen systems now. And there are two main systems. There's the low flow systems, the high flow systems. You know the low flow systems pretty well. These are nasal cannulas, face masks, or with partial or non-rebreathing bag. And as a group, these can deliver up to 15 liters per minute of oxygen. That gives us around an FiO2 of 60%, depending on the patient's peak flow rate. And I just want to point out something. Your peak inspiratory flow rate is the maximum rate at which air is or gases are inspired. At rest, a normal resting patient will pull in or inspire at around 30 to 60 liters per minute. If we are providing that patient with oxygen at 15 liters per minute, where does the rest come from? In the low flow systems, this is supplied by entrained air around the face mask. And as you can imagine, that will dilute the oxygen that we are setting the patient on. And so in a large number of cases, we will use high flow nasal cannulas if patients are deteriorating on those settings. And distressed patients can have a peak inspiratory flow rate as high as 120 liters per minute. I think I had mentioned that already. And so your high flow nasal cannula already is starting to offer significant benefits. But in addition, it can supply FiO2 of up to 100%. It can warm the gases, which can be between 31, 34, 37 degrees centigrade as a setting. It humidifies the gas to 100% relative humidity and can offer high flow rates up to 60 liters per minute. And patients tend to be more compliant because they're able to talk and eat without needing to remove it and without desaturating. So this is just a quick description of the difference between the high flow and the low flow settings. And here we will say, for argument's sake, that the patient is entraining 20 liters per minute of room air, which has 21% oxygen. So in the low flow system, say this is 6 liters via nasal cannula, which you really shouldn't go over 5. But just for the example, we're providing 45% FiO2 if we give 6 liters via nasal cannula, and hoping that that is what gets down into the lung. But as the patient's peak inspiratory flow rate causes entrainment, it mixes within the nasopharyngeal airspace. And so what the patient is actually receiving is much, much closer to the 21% than to the 45. And if, for instance, we are giving 60 liters per minute at an FiO2 of 45%, on a high flow nasal cannula, then in the retropharyngeal space, in the nasopharyngeal space, we will be giving a gas flow or a gas mixture that's actually much closer to a 45% FiO2. And what studies have shown is that, mouth breathing may cause the flow to escape. So once it is that the patient is breathing out against the nasal cannula, pressure is transmitted down into the airways. And if a patient's mouth is closed while this is going on, the trachea actually generates a pressure of about 2 centimeters of water, depending on the flow. But once the mouth is open on the same settings, that can drop to as low as 0.6 centimeters of water. So we're losing some of the benefit of the high flow nasal cannula if patients mouth breathe. And so this is actually a good thing, the transmitted pressure. Patients receive positive end expiratory pressure while on the high flow nasal cannula. And for every 10 liters per minute of flow that we set, these patients receive 1 millimeter of mercury of PEEP, keeping in mind that physiologic PEEP is only about 4 or so millimeters of mercury. And what they found is that patients who are receiving high flow nasal cannula have increased lung volumes at the end of an expiration, which is their functional residual capacity. And so it means that there is a significant amount of alveolar recruitment that occurs when patients are placed on this device. Because of the increased pressures, there is reduction in extravascular lung water, some of the interstitial fluid that is seen. And by raising the intrathoracic pressures or preload, the preload is decreased, and that helps patients who have a heart failure component. And in addition, there is the benefit of CO2 washout from the nasopharyngeal space. So when a patient exhales, some of that exhaled air, which has CO2, of course, will line the nasopharyngeal space, but with a high flow nasal cannula, that's washed out. And so we're already offering benefit to patients who are hyper. So cannula is working well. We expect to see an improvement in their respiratory rate, in the level of hypoxemia, the level of their distress. But one of the other methods that has been documented is the respiratory rate oxygenation index, or the ROX index. And it's measured at 12 hours, the 12-hour mark after being placed on high flow nasal cannula. It's a double division. It's the ratio of the SpO2 to FiO2 to the respiratory rate. And you'll get a figure when you do that. The score should be greater than 4.88 if we want to say that the patient is benefiting from the high flow and should continue on it. When the scores are less than 4.8, it's less indicative. It's less indicative of whether or not to convert the patient to mechanical ventilation. But certainly once the scores are higher than that, then we can be more confident about leaving the patient on the high flow nasal cannula. Okay, so incentive spirometer is also a widespread recommendation. Well, this is probably the most respiratory physiotherapy that these patients will receive because it is self-administered. And it's a form of physiotherapy known as sustained maximal inspiration. And when patients use this, not only do they have alveolar recruitment, but we have mobilization of secretions as well. And it's usually used 10 times in an episode, and each episode is repeated every 1 to 2 hours. Those are the usual recommendations. Other frequencies include 10 breaths 5 times a day or 15 breaths every 4 hours. But we usually recommend 10 times every 1 to 2 hours. And when patients use the incentive spirometer, they're mimicking a natural yawn or sigh. They actually come in two forms, a flow-oriented versus a volume-oriented form. And we're used to seeing the flow-oriented form, that's with this ball. But the volume-oriented form has a piston that rises to a set tidal volume. And the patient holds the device. After a normal expiration, puts the device in their mouth, closing their lips, and they breathe in slowly through the mouth and through the device, deeply, slowly, for as long as possible through the mouth. When they've gone the maximal inspiration in this method, they hold their breath for about 5 to 10 seconds and then expire. And as you can imagine, if there are secretions, the patient may cough, may start to cough them up. With the volume oriented, the piston rises to the target tidal volumes, whereas with the ball, the resistance is what we change. And we'll see markings on it, 200, 400, 600, 800, 1,000. And we can turn that knob. Usually we start at 2,000. There's a little arrow that lets us know where the setting is. And that's how we give the patient targets for inspiration. So by far and large, the intervention of pronation is one of the most consistently effective interventions for these patients. Studies have shown that as much as up to 92% of patients who have received that intervention of pronation have improvement in their oxygenation. And it is true experientially as well, anecdotally as well. But I just want to describe some of the changes that happen with pronation. So a supine patient with ARDS is going to have an increased lung weight, and most of that lung weight due to gravity will rest in the posterior aspects of their lung, the basal lungs. And the lung water collects there as well, maybe even effusions collect there. So these alveoli are collapsed as a result, the dorsal alveoli collapse as a result. And when the patient inspires, instead of of air flowing into these collapsed alveoli to open them, it preferentially goes to areas with lower pressure, which tends to be your ventral alveoli. And so your dorsal alveoli collapse or stay collapsed, and the ventral alveoli over-distend, which in certain settings predisposes them to barotrauma. When you put the patient prone, the heart comes off the lungs and rests against the sternum. So already you're having less weight against the lungs. But the alveoli that were in the dorsal area and collapsed are now being expanded because of the lung weight being lifted off them. They're recruited. The ventral alveoli get some relief from their overdistension, and you have improved VQ matching as a result. Even the edema that would tend to settle in the prone position towards the front of the chest is less. And because we're recruiting alveoli, we're increasing the functional residual capacity. And so it really is quite effective. It's usually done for about 30 to 120 minutes in the awake patient. Sometimes their saturations improve by 5%. Sometimes it improves by as much as 20% just by proning. And the goal is to keep their abdomen free. Sometimes that will involve them lying on a roll around their pelvis. But once the abdomen is free, the diaphragm will descend. And so you'll actually have better excursion of the lungs as a result. So there are a few cases in which we want to rule out other untoward pathologies besides ARDS from, severe COVID pneumonia. And one of those is bronchospasm, if there's a bronchospasm component. Unfortunately, not having a stethoscope means that we have to be a bit more cunning or savvy with our detection of bronchospasm. And sometimes we'll ask the patients if they feel any chest tightness, if they've wheezed in the past, if they have a family history of asthma or atopy, if they have a history of smoking. And when we look on the x-ray, if we do see hyperinflation, then we may suggest that the patient receives bronchodilator therapy. That's often, in the form of a meteor dose inhaler that allows the patient to, be in control, empower them to be more active about their health. But receiving the nebulization via a face mask with a nebulization chamber can be done over the high flow cannula as well. And in patients who we think may have a COPD component, sometimes we do add Symbicort to their therapy as well. We want to distinguish a fluid overload component. And again, we do have to we do that without listening to their chest, and that's often using the x-ray. We may look for features such as carpalization of the vessels, fluffy infiltrates. But if you're in the room with the patient, you can check for peripheral edema. You can ask them about their fluid intake. Often these patients are fluid restricted to 1.5 liters per day. We help lock their IV access, and we recommend that intake is largely via the gut. If they do have the benefit of an input-output balance, if they have a positive balance and they've deteriorated, then they may benefit from getting either a stat dose of a diuretic of Lasix, or if they're already on maintenance Lasix, we may opt to increase the dosage. Yes, so usually we would see ground glass, widespread streaky infiltrates as a result of COVID pneumonia, but this is a classic non-cardiogenic pulmonary edema picture. And then finally, we do have to rule out pulmonary embolus. By far and large, these patients have been documented as having a high risk of thromboembolic phenomena. And there is enough evidence to support giving them the high dose prophylactic Clexane dose, which is usually around 60 subcut once a day or 40 BD. And if we are presuming that they do have a pulmonary embolus, we may put them on as much as 80 BD. So if after we have done all this troubleshooting, our patients continue to deteriorate, then when do we intubate? We try not to do that. We don't make that decision lightly. But if the patient continues to have hemodynamic instability or declining mental status, worsening respiratory failure despite all our interventions, then we may have to intubate them. And the reason why we try to avoid that and why we emphasize, early intervention is because it does carry a poor prognosis. So far, none of these patients have been able to go home. Also, additionally, we find that the elderly also are poor prognostic indicators. Being elderly, having diabetes, having obesity are also poor prognostic indicators anecdotally. And usually once it is that we're at the point of mechanical ventilation, most of these patients will have other organ damage as well, especially renal failure. They tend to have multi-organ dysfunction syndrome by the time they are intubated. So in conclusion, if you find that you have been, shipped to a satellite site, I hope this has allayed some of your fears. There are a number of interventions that you can make to improve your patient's oxygenation. Early interventions are the most effective. And this is the enrollment key is it's hypoxia. Thank you. And these are my references. Oh, I want to play a video of the high flow device being set up. Yes, you come up there. And while that is going on, it will go on silently. While that is being done, we can answer some of the questions. This is Cassie, our respiratory therapist, Cassie Brennan, and demonstrating how the high flow machine can be set up.
Okay, Dr. Turnquest, thank you. We are not seeing the video though.
Oh no. Okay.
So you may still have to upload it.
Yeah. Here we go. Are you seeing it now?
You've started screen sharing, and have you picked the video?
Yes.
So we can give it a couple minutes. I don't know if with your internet issues, it may or may not, but what you can do is you can attach it to the end of the presentation, because as a reminder to everyone, the presentation will be available for viewing after the fact. The link will be on the University of the West Indies website, the Sunshine Learner website. And so for your colleagues who may have missed the presentation, they will have access to it, as well as if you were not able to take a picture or write down all that useful information about how to estimate our oxygen availability, you can get all of that off the presentation on the website. So thank you very much, Dr. Turnquest, and thank you for showing us how to estimate how much oxygen we have left, because yes, you are right. Amongst our level, that is something that brings a lot of anxiety when you think you may not have enough oxygen left. We have a question from Dr. Chelsea Brown. Good morning. What would be the end goals of treatment for hospitalized patients with moderate to severe COVID? Requirements for discharge from the critical care standpoint.
Okay. Well, usually once it is that we've been called to see patients, there is a significant amount of respiratory distress. And our goals for discharge, we follow these patients up until they're discharged home. And so we want these patients on room air, maintaining their SATs above 94%. They should be comfortable in terms of their level of work of breathing, and they shouldn't have any major organ dysfunction that is reversible. So for example, no electrolyte imbalances that are life-threatening. We want to have them hemodynamically stable, all right? They shouldn't be in hypertensive emergency, for example. And we do try to keep patients with until their glucose has achieved a measure of control. What we found is that, especially once they're given steroid therapy, they do have some amount of glucose impairment, and we've had to institute aggressive glucose control, and sometimes that warrants an extra day or two in the hospital setting before being discharged home.
Okay, thank you. And Dr. Ramphal has a couple questions. We are going to let him unmute his mic.
Good morning.
You can ask his questions.
Morning, can you hear me?
Yes, we can, Dr. Ramphal, go ahead.
Okay.
Okay, we heard you, and then I think you muted.
Okay, Dr. Turnquest.
Good.
I can hear you.
That was really, for me, a really well done presentation. I really want to compliment you on how you go into the pathophysiology and explain it in the manner that you did. I think we need to have more of that kind of thing. And I really want to compliment you on that. I have a question to ask you regarding, well, let me put it this way. Pronation has been something that we have known that would help a lot of people in a lot of situations who are in prolonged ventilation for many, many years, and has been extremely difficult to get it performed when we know it would be helpful. And I'm wondering if this COVID thing has been helpful from a point of view of instructing us how to actually accomplish pronation so that we could start using it in more patients who are not COVID patients, but who are other patients who get these same pathophysiological changes due to supine ventilation and supine position. And can you just tell me, let's say you've had some of these patients. I know you've had some 300-pound people with COVID that you've had to do pronation. What allows you, how do you get that done? How do you actually achieve the pronation in these patients? And what is the cycle that you use in terms of how time and pronation, etc.?
So the nursing, that's a nursing-led involvement, to be quite frank, intervention, to be quite frank, because what we have found is that when the nurses are motivated and understand the benefit of pronation, then the patients are far more likely to get it in a consistent manner. So essentially, what in the awake patient, it's fairly easy for the patient to do their own pronation. We ask them to turn on to their belly. Sometimes you have patients who are compliant with that. Obviously, you have to assess their mental ability to cooperate, etc. But once the patient is alert, oriented, and is able to follow commands, they can turn themselves prone. As I had mentioned, it is important for them to benefit from the prone position, for their abdomen to be free to do its excursion. And so sometimes we will put a roll or a pillow under the pelvis and then one by the head with their arms over their head like this and their head turned to the side, to one of the sides. It's like most people would if they were sleeping on their tummy. And so it's comfortable for the patient to do and to maintain. In the awake patient, we will do that for up to 2 hours and then give them a rest. For the ventilated patient, I think that's where we'll find a lot more reservation on the part of the nurses. Usually that will involve several people turning the patient, one at the head, a porter, and a nurse. If there's a draw sheet under the patient, that helps as well to turn these heavy set individuals. But once it is that you have 2 or 3 people, it is you know you're able to do it. It's something that's a manageable intervention. And once again, their head is turned to the side. The hands are over the head in a sort of Superman position. And we do put the rolls by the chest, the zippy sternum area, and also by the pelvis.
Thank you very much, Dr. Turnquest. And just to finish that up, Dr. Grant had asked how often. I know you said 30 to 120 minutes while the patient is awake, but how often?
Well, we tend to do that with, sorry, 1 second. Right, we tend to do that every 2 hours or so. In the awake patient, they can be turned prone.
Okay, thank you very much. And we do have some other questions. Dr. Chisholm would like to know, I think you did mention it though, roughly what percentage of patients make it off the vent with severe COVID in your experience here?
None. It's a very poor prognostic indicator, very poor prognostic indicator. And in fact, as I said, it's not a decision that we make lightly. The patient is made aware of the risk if they are awake at the time, and the relatives are consented for the procedure as well. You know, we make sure everything is clear, that all the cards are on the table. They do not do well for a number of reasons. They have widespread organ dysfunction. At this point, they're pretty far gone. They're in a severe setting. And then they're in a satellite site as well. So they tend not to do well.
Okay, and then Dr. Griffith had a question about our high flow oxygen capacity. What is that like? Adequate, not adequate?
Okay, well, you know, I just want to say kudos to our respiratory therapists and to the nurses and doctors who have been helping us on this front. A number of them have taken on learning how to set up the high flow nasal cannula and do so, you know, just as well as we do. It is, I think we have about 6 available for South Beach. And the rest, I think maybe about another 6 or 5 are available for between the legacy unit, A&E, and the rest of the wards. So yes, we definitely could benefit from having more machines, but at this point in time, if a patient needs it, they have been receiving it. I think the most important thing is to learn how to care for your high flow device, which is one of the videos that I have been trying to show. It's not anything technical. It's quite simple, and it's an automated process, really. It self-cleans, and once the packages are available, everything is within the package except maybe the oxygen tubing, which you can easily get that from your nursing staff. So in terms of capacity, that is adequate. So far, we could have if you want to donate some machines or get someone to donate machines, feel free. We welcome that. But so far, it has been adequate. Whatever needed has been good.
And Dr. Gabrielle Hunt-Burrows would like to thank you for a very comprehensive and insightful presentation. Okay, we have some additional questions. Dr. Conville Brown, well done, Dr. Turnquest, and extremely practical. Excellent presentation, Dr. Turnquest. So it was very, very insightful and useful for many of us. So thank you very much. I do have one more question here as it relates to the morbidly obese patient with the diagnosis pre-admission of asthma. And great effort is made to get their saturation to around 98% plus. What level of oxygenation should we aim for in such patients once they are comfortable? Do you understand the question?
Yeah, I think I understand what you're trying to say. So I did mention that the target saturations don't necessarily have to be 98%, and a lot of that is going to be considering, the degree of severity of the ARDS, component. If we have an ABG, we can measure the patient's PA2 to FRA2 ratio. But we do have other ways of measuring the severity of the COVID infection. I think there's a breast PS score as well. And depending on their saturation when they first present, how they are on room air. But for the severe ARDS patients, we do tend to accept SATs over 88% for them. The truth is that the basal metabolic rates are sufficiently supplied with the oxygen that they need for their Krebs cycle, etc. on a cellular level, even with that degree of hypoxia. And so if we find that in order to get the SATs over, 95, we have to be putting the patient on 100% oxygen. We know that there are risks with that. So having evaluated that patient and understood that this is not something that we want to maintain for more than absolutely necessary, then we may opt to target lower saturation so that we have a more balanced oxygen therapy without too much toxicity.
Okay, and while you're talking saturation, you mentioned that we should not take the patient off oxygen to measure the oxygenation on room air. And if we look at the notes, we see that that is routinely being done. So one, is this a practice that we should review? And two, how should we approach it? Because it's done to determine, the ability to have the patient discharged comfortably.
All right, that's a good question. So the weaning protocol that you come across will sometimes recommend that the patient, if it's like a nursing-led protocols, I've seen them where they recommend that the oxygen be discontinued. these are not usually patients who are receiving high flow systems. When they are receiving oxygen in such an intense support device, then the best thing for them to best protocol is for us to gradually increase their oxygen. We know they're going to be statically disconnected, you know, and really what I have seen is, oh, we put the patient on room air, and by the time it reached 76, we were too nervous, so we put it back on. So you see, we've accomplished nothing. We've accomplished nothing by doing that. Yes, we know that the patient might still be severe, but we knew that already from when the patient presented. And so what you will see anesthesia the COVID difficulty do is that we gradually turn down the FiO2. And sometimes it's as little as maybe 1 or 2% per day, maybe 5% per day. We actually stand up in the room if we need to with the pulse ox on. And as it's decreased, we look to see if the saturations are still within the target range.
Okay, so that holds true for patients on nasal cannula oxygen as well.
Okay, so if you're on minimal oxygen, the truth is that you can have a faster wean. But yes, you should always be going gradually. For somebody on 2-3 liters of oxygen via nasal cannula, yes, you can discontinue that. But certainly for somebody on, say, 15 liters per minute, 10 liters per minute, you should be titrating it gradually over a period of time.
Well, thank you very, very much, Dr. Turnquest, for such a wonderful, interesting, and helpful presentation in this COVID time. And we have lots of congratulations to you from Dr. Stephen Boodoo, Dr. Sai Pei, Dr. Chelsea Brown. Thank you for an awesome, excellent, great presentation.
You're most welcome. It was my pleasure. Sorry for the late start.
And thank you everyone for your participation. Please remember that the CMEs or the CME talks are available on the University of the West Indies website, so you can look at them after the fact, share them with your colleagues, and claim CMEs. Also, if you're interested in getting some of the slides, they will be available there. Our next CME will be on Wednesday the 14th, where it's going to be exercise prescription, a pill for every patient. And on Friday, the 30th of October, we will have a morbidity and mortality presentation. And I would like to send a big, big thank you out to my one-man production, camera, musical selector, IT team, Dr. Darren Halliday. Thank you so much for making this possible. And thank you to all of you. Have a great day.